Dear Chairman, thank you very much for inviting me for this meeting, the Bifurcation Club 2021, and hope to meet you physically next year, inshallah, after the COVID-19. Each of us would like to simplify the procedure, but sometimes the winds come with unexpected scenarios, and this is what happened in this case. So what looks easy is not usually easy. My patient is 60 years old, female patient, hypertensive, smoker, complaining of typical exertional chest pain, the maximum medical treatment with normal echocardiography and the normal resting ECG and positive stress test. I decided to do coronary angiography for her, and I found made LED calcified lesion with 80 to 90% stenosis. This is the coronary angiography of the patient here. Very tight stenosis at the level of the diagonal, sizable diagonal branch. This is the tight stenosis. I decided to prepare the lesion by using a balloon 2.5 by 15 balloon at 12 atmosphere, inflated the balloon at 12 atmosphere. And this was the surprise after inflation of the dilatation. Perforation at the carina with the diagonal branch. So how do you stop bleeding from the coronary artery? I started by the regular method using ballooning for the perforation for 10 minutes. After ballooning for perforation, still the perforation is present. Balloon inflation was continued for 10 minutes. ST segment elevation with BVCs and OCG. Patients suffer from chest pain. The blood pressure gradually decreased. This was a very stressful condition. How do you stop bleeding from the coronary artery? So I decided to go to the next step to search for the output graft stent. But this was the second surprise. I didn't found the sizable graft stent at this moment. So do you know, over the wire balloon, I was lucky and the patient was lucky. The over the wire balloon, as we see here, has two lumens, lumen for the wiring and lumen for inflation. So I pulled back the wire. I injected self-blood in this lumen, and the other lumen, I inflated the balloon and to block the part of the perforation and maintaining the distal diffusion for the myocardium. I put a long wire, 300 centimeter, then I put over the wire the balloon, and then I inflated and pull back the wire, and I injected self-blood into the wire lumen of the over the wire balloon by putting another sheath in the contralateral side of the femoral artery and taking self-blood and then re-inject this blood into the lumen of the wiring in the over the wire balloon. This is the principle of this balloon, of this my technique. I pull back the wire, inflating the balloon, injection of self-blood into this lumen. So I'm maintaining the distal diffusion of the rest of the myocardium. After this method, injection of self-blood, the ST segment elevation was decreased, and the chest pain of the patient disappeared. I maintained the inflation for 20-25 minutes continuously with continuous injection of self-blood. Here, as we see here, over the wire balloon at the site of perforation and distal perfusion is maintained. Here, I blocked and I inflated the balloon at the nominal pressure. I think it was 8 or 9. Then I put the guide wires, deflating the balloon, and reevaluate. And this is the final angiography after the over-the-wire balloon. The perforation is sealed. Good BTCA. This is another projection. Here also, good BTCA. I decided after this good angiographic result to stop at this level and put the patient on dual antiplatelets and on the maximum medical treatment and stop at this level. My take-home message is PCI is not just passing wire, inflating balloon, or putting stents. It's a matter of how to deal with complications. Over the wire balloon could be a simple method and effective method to seal perforation of type 2 and 3. Thank you very much for your attention.
Thank you very much to the chairman of the Bifurcational Club and the Bifurcational Club for this invitation to present my case, which title is One Moment Percutaneous Treatment of Severe Aortic and Left Main Severe Stenosis, plus all three arteries with stenosis in patient with very low ejection fraction by aortic balloon valvuloplasty, Impella implantation, and complete revascularization. By the way, this case was complicated with the femoral artery perforation due to the failure of MANTA closing device, result with implantation of covered peripheral stent. Operators, Dr. Bernardo Cortese, Iardino, Dr. Gaetano Di Palma, and me, Dr. Fouladvand. Department of Cardiology, San Carlo Clinic, Milano, Italy. We're talking about a patient of 8 years of age without any previous disease, that he came in our hospital with dyspnea lasting for several hours. And at arrival, her ECG demonstrated these signs of ischemia on the precordial leads and signs of the pulmonary congestions, and her laboratory findings were high sensitive troponin that was more than 3,000 nanogram per milliliter. The patient was prepared with DAPT treatment and for the treatment of the next day with angiography. And by the way, her echocardiography demonstrated severe calcific lesion with stenosis of the aortic valve and ejection fraction something about 30%, so a really difficult patient. Next day, angiography demonstrates osteostenosis of the right coronary artery and stenosis of the mid segment and severe stenosis of the left main and circumflex and proximal to mid LAD. Here we can see the situation with the left main. I think it's a really dramatic situation with the left main and also the mid LAD. So the patient came on February 2020. The plan was same-day PTCA of the right coronary artery, and the next day after the evaluation, vascular evaluation, Doppler evaluation of the iliac arteries, to make the aortic valvuloplasty for facilitation of the Impella placement and left main treatment with two stents, double stent treatment of the left main, and possibly treatment of the circumflex and the LAD by the drug-eluting balloons. And then obviously removing of the Impella and closing of the access site. You see two stents in the right coronary artery with quite good result. Next day, placement of the temporary pacemaker, valve 20 millimeters balloon for the aortic valve valvuloplasty, and the valvuloplasty while the pacemaker is working. Once did that, we placed from the left femoral artery the Impella device, and the Impella was turned off, waiting to reach the safety of steady of 2.5 liters per minute hemodynamic support. After that, from the radial artery. We started the predilatation of the using the 7 French EBO catheter. We starting preparation of the left main with first with normal balloons. After that, with semi-compliance balloons. After that, with the non-compliance balloons separately or in kissing manner, and with the unsatisfactory result. Then we pass to the scoring balloons, again the same thing. So we decided to treat the patient, the left main, with the shockwave balloon 3.0 50 millimeters, 4 sequentials for the left main LAD, and the same for the cycles for the left main circumflex artery, with obtaining this result, which is acceptable for stent placement. So we decided to place one dedicated stent, the only one remained in the market, a biostent from left main to the circumflex artery. This is a drug-eluting stent, and this is the immediate result after of the this stent placement. Then we performed predilatations of the mid-LAD, proximal LAD, and ostial LAD, and then with a non-compliant balloon, and then we placed a drug-eluting stent from left main to the LAD, something like a short culotte stenting, finishing the left main treatment according to the bifurcation, European Bifurcation Club consensus document, with the pods, and then with the kissing balloon, and then with the repod. And after that, for reducing the metal non-using stent, we use the drug-eluting balloon for the left descending artery proximal mid part. The same thing we performed for the circumflex artery, with the final result. This is a quite acceptable result. So finishing the procedure, remove the Impella device and close the access site with a Manta closer device. The patient then was transferred to the coronary care unit. Exactly 5 to 10 minutes later, patient demonstrates complaint, intensive pain in the lumbar and iliac region with a severe hypotension, and the immediate vascular ultrasound demonstrate a rupture of the femoral artery, and the hemoglobin in urgent evaluation from 13 grams per deciliter went down to the 8 grams per deciliter. The patient immediately was retransferred to our cath lab while compressing the femoral artery. And from the right femoral artery by crossover, we saw the rupture of the femoral artery exactly on the place of the Manta closer device. So we put a cover stent on this place here. You can see the cover stent, and the final result was quite good. The patient remains in the department in the cardiology for 2 weeks at least, and after that she was transferred to the rehabilitation unit. This complex structural aortic valve treatment and coronary multivessel procedure involving all the arteries has thus important implications. In time of pandemic restrictions, decision of treatment must be done using the available in-hospital facilities. The presence of aortic valve stenosis and multivessel disease and low ejection fractions require contemporary preparations of aortic valve for hemodynamic support during coronary angioplasty. Structural complex coronary procedures requires meticulous procedure plannings, as in our case, and vessel preparation is very important. It's even must before stent placement, using any kind of the balloons and the plaque modifications, rotablation, arterial catheter, shockwave, and whatever it else. Two-stent strategy, particularly when treating multivessel coronary disease, is important, but when it's possible, it's not bad. I am saying it's not bad to use dedicated stents, aiming to reduce excessive metals in such a complex patients with multivessel disease. Drug-eluting balloons are valid, really valid alternative to the drug-eluting stents. And unfortunately, when you have a vascular access site complications, particularly when they are dramatic, in the experienced hands, those complications can be managed within the cath lab percutaneously. Thank you very much for your attentions. Again, operators Cortesi, Ardino, Di Palma, and Fouladvand from Italy. Thank you very much for your attentions. Thank you.
Good morning, everyone. I want to thank the chairpersons of the EBC for giving us this opportunity to be part of this wonderful meeting. So I'll be presenting a calcified left main case from India. So the patient was an 82-year-old male who presented to us last year with history of class 3 angina for a few months. He was a known case of CAD for last 20 years on medical follow-up, and he also had unstable angina for a week. He had negative biomarkers for myocardial infarction and had an ejection fraction of 40% with inferior akinesia and normal valves. On the diagnostic angiogram, we found a diffuse triple vessel disease with critical distal left main lesion. His coronary arteries were heavily calcified, and there was long segment disease in the LAD and the circumflex. As we can appreciate in the cranial projection, the LAD was diffusely diseased, heavily calcified, and was also giving some collaterals to the right coronary artery, which was diffusely diseased with an occluded PDA. In the spider projection, we appreciate eccentric lesion of the circumflex, which had a tight ostial lesion and diffuse disease about 70 to 80% extending beyond 20 millimeters into the circumflex body. So the patient was calcified left main triple vessel disease and was discussed in the heart team meeting for the best treatment strategy. Considering his age, he was refused for CABG and was planned for PCI strategy. For PCI, first we needed to decide the best strategy for the distal left main. Here we thought it was a Medina 111 lesion with heavy calcification and long segment disease of the circumflex. So we decided to treat with an upfront 2-stent strategy for the left main. We decided to use a 7 French guiding catheter and insert a prophylactic IAPP from the left groin, as we did not have Impella at our institution, and to do the procedure under imaging guidance with rotablator upfront, considering long diffuse segment disease, which was heavily calcified in the LAD. So we used a 1.5 millimeter burr for the distal left main, which crossed successfully. And then we used the same 1.5 millimeter burr for the mid LAD, which crossed after some time, as there was some tortuosity in the mid LAD. So after successful rotablation, we protected the diagonal and we did the first IVUS run. On the IVUS, we had 3 points of interest: the distal, the proximal LAD, and the distal left main. So all around the LAD, we saw circumferential calcium, as we can see in point 1, with an MLD of 2 millimeter and some rota effects from 6 to 9 o'clock. The calcium appeared thick. At point 2 again, we had thick calcium, which was circumferential, and thick calcium from 12 to 6 o'clock. And in the distal left main, we had a calcified nodule from 11 to 1 o'clock with favorable wire bias. After the IVUS, we took a 2.5 millimeter NC balloon, which failed to dilate at 28 atmospheres. So we were left with a few options. One option was to use a 2 millimeter burr based on the IVUS findings and MLD of 2 millimeter. But we thought probably the risk of slow flow and no flow will be very high. And also the patient had an occluded right and a very advanced age. Second option could have been to use a cutting balloon at high pressure, which sometimes does not work, as the calcium appeared very thick on IVUS. IVL, we thought, is probably the best option, considering a 360-degree ring of calcium and knowing that IVL and rotablator can be very complementary. So we used a 3 millimeter IVL balloon for the mid to distal LAD and gave 40 pulses each, after which the balloon dilated successfully. Following which we used a 3.5 millimeter IVL balloon for the proximal LAD, which also dilated successfully after 40 pulses. After this, we stented the proximal to mid LAD lesions with 2 overlapping drug-eluting stents, which expanded well. And then we turned our attention to distal left main. Distal left main, first we treated with a 3.5 millimeter IVL balloon, and we gave 30 pulses at this location. And then we used the 3 millimeter IVL balloon, which we had used for the distal LAD, to treat the ostium of the circumflex. During the second cycle of our IVL balloon at the ostium of the circumflex, the IVL balloon ruptured, as we can see on the left panel. And this caused a large hematoma in the left main and the circumflex. The cause of the balloon rupture could have been nodular calcium at this site, as we had not done rota in the ostium circumflex, or balloon properties. We immediately stented the left main bifurcation with a minicus strategy and stented the circumflex with the 3 into 26 and left main to LED with the 3.5 into 26 millimeter DES. We did a pot in the left main with a 5 millimeter balloon, and then we did a final kissing balloon with 3.5 and 3 millimeter NC balloons in the LED and circumflex respectively. We got a good angiographic result, as we can see in this caudal projection. And we got a good angiographic result in the cranial projection with no occlusion of the diagonal. After this, we did an IVUS, which showed well-expanded stent in the distal LED. Here we can see pre and post of the distal LED, where we got an area of 9 millimeter square. And this is the pre and post IVUS of the distal left main at the site of the calcified nodule, where we got very good stent expansion, which is very circular and area of almost 16. We could not do IVUS, unfortunately, in the circumflex, as the patient had a distal wire perforation, which we had to balloon occlude. So in the final IVUS, all across the left main LED, we got areas in addition of almost 9 millimeter squares and 16 millimeter squares in the left main. So these were the final pictures in the cranial and caudal projections. So in summary, we think that diffuse calcified lesions are always a big challenge, and it is our duty to do a safe procedure for our patient. Imaging is extremely beneficial in such cases to select the best device for plaque preparation and also to see the results of our plaque preparation. Imaging is also important to prevent complications. And we believe that rules of life are equal to rules of tools. So rules of life, like we all have our own weaknesses and we need to collaborate with other people to achieve more. Similarly, all the tools have their own weaknesses and strengths. So rotablator, IVL, cutting balloon, they all have their own strengths and weaknesses, and they can be combined in a synergistic manner to achieve better outcomes and safe procedure for our patient. And upfront use of IVL should probably be avoided without prior imaging to prevent complications and to use it more effectively. So the harder it is, the softer we must go. And I hope we meet Dr. Goran and Dr. Eve and the EBC members again. So thank you so much for allowing us to be part of this wonderful program. Thank you so much.
Thank you for the introduction. This is a 55 years old male patient who complained of exertion chest pain for 5 years, which has been controlled with medication. But it was aggravated to a CSS class 3 since 20 days ago. He was hypertensive and a chronic smoker and had hypercholesterolemia. And the ejection fraction was normal and there was no reasonable motion abnormality. But surprisingly, first angiography of left coronary artery showed the left main total occlusion. And the right coronary angiography showed the abundant collateral circulation to LAD and also circumflex from RC. This is a bilateral injection. You can see that the total occlusion is very short, and the circumflex comes just after the CTO segment. And unfortunately, circumflex ostium looks like diseased. This is the true bifurcation left main CTO case. So we started with 7 French XP 3.5 for left and 6 French JL4 guiding for right, and the UV3 guide wire and in the Corsair microcatheter. So we tried integrated approach first because it's very short, and after 10 to 20 minutes trial, we successfully wired the Concus Pro to diagonal, which was exchanged to the soft wire run through. Actually, we are talk about the subintimal location of the wire. This is possibility. We are not sure. And with the help of Sasuke catheter, which is a double lumen microcatheter, we very easily get that wire down to LAD. This is IVUS. This is LAD. So the wire is traveling almost in the true bifurcation. Vessel size is more than 4, almost 5, and this is left main and true bifurcation. So we did a 3.0 balloon, 12 atmosphere. And we found that the ugly looking ostium of circumflex ostium, the angle is really unfavorable and there was a very tight stenosis. There might be some flex shift from left main to circumflex. It is very difficult wiring. But the diagonal ostium, I didn't think that we need a wire protection. You can see ugly looking circumflex ostium again. The plaque is here to here. So actually, the first thing we did was the IVUS marking, because we are not really looking at the true circumflex ostium, but actually it was not so helpful. Anyway, we started wiring with the UV3 wire in Sasuke and XTR, the more softer wire, the probe in the circumflex. And actually, we found that the wire is getting into the circumflex ostium. The wire prolapses often because there is no support. So we changed the strategy with the support of the 3.0 balloon. We tried the harder, using XTR and UV3 in the Corsair microcatheter. But during the procedure, actually, we found that the circumflex was totally occluded, and next thing we considered was a retrograde approach for circumflex. But unfortunately, circumflex is supplied by the very tortuous epicardial collateral. It's nearly impossible to travel. So circumflex totally occluded, and the very complex collateral circulation. So what to do next? We can consider 4 options: Concus Pro, Cito procedure for circumflex, and PAD for left main, and we tried wiring, and retrograde approach for circumflex anyhow, and left main to LED standing first. And we selected option, last one, left main, LED standing, and wiring, trying wire the left circumflex afterwards. So we implanted the 3.5 by 23 millimeter Zeiss Sierra. Of course, the circumflex is completely gone. And epicranial, you can see the complete circumflex complete gone. But we know the location of the circumflex ostium, so we can try wiring here. The first thing we should do for the wiring is the proximal optimization technique. So to widen the cell struts on left main standing, we have a better chance to wire the circumflex ostium because wider space between stent struts. And this is a contralateral injection. You can estimate the location of a circumflex. After about 5 minutes, try to pass the wire. Suddenly, I felt the release of the wire. This is UV3. I was surprised. But in this view, actually, wire doesn't look like in the right way. But the epicardial view, you can see the wire is maybe in the true lumen. Anyway, I felt a release. And so I with confidence, I progressed wire to the circumflex and the 1.5 balloon and the change to soft wire. You could see the large obtuse marginal, like here. We did 3.0 balloon, the 10 atmosphere, and wire replaced, repositioned to obtuse marginal. This is IVUS examination from here. Actually, this is ostium of circumflex. The wire travels the true lumen. So next step is very easy. I try the tap technique with the Science Sierra 3.5 by 23 millimeter circumflex with the balloon and stent balloon in the LED. And implanted low pressure, considering the small size of obtuse marginal, pull back, higher pressure, and finish with moderate pressure, kissing ballooning. This is IVUS from LED. It's wide open and very short. This is IVUS from circumflex. circumflex ostium is widely open, and you could see the very short stent carina. This is the final angiography. The diagonal ostium is pinched, but we have no problem with that, of course. Okay, this is the end of my presentation.
Mr. Chairman, thank you so much for the invitation to present at the EBC meeting 2021. The title of my presentation is A Case of Left Main Quadrifurcation Stenosis with Very Long-Term Follow-Up. I have nothing to disclose. The patient was presented with non-STEMI. He has a history of breast angina since 1 week. ECG showed negative T waves in P1 to P5. Laboratory investigation revealed elevated cardiac enzymes. He was treated with standard medications, including dual antiplatelet and also enoxaparin. The coronary angiogram revealed left main quadrifurcation stenosis with critical stenosis in the distal left main and also critical stenosis in all side branch osseae as shown here. And there is also stenosis in the first intermediate branch, and flow in the LAD was sluggish, and there was no collateral from the right coronary artery, which was normal. You know that there is no technique described to treat quadrifurcation stenosis in the current guidelines or in any consensus. So we tried to apply the risk stratification models, a syntax score, Euroscore, GRC, and NERS scores, and we concluded that the patient was in a high PCI risk, high CABG risk, and he also had a high risk for MACE and stent thrombosis. However, the patient declines coronary artery bypass surgery. So if we want to do quadruple stenting, we have to be mindful that our guiding catheter cannot accommodate all stents. So initially, we open up the stenosis in the LAD ostium because flow in the LAD was sluggish, and followed by opening the first intermediate branch ostium, followed by stenting of that vessel, and then we have to use two guiding catheters. We have to avoid twisting of the guide wires, and we should know the technique to deal with it should this happen. So then we dilated two other side branch osseae, and this is just to show all osseae less stenosis after balloon dilatations. And following this, we did sequential quadruple kissing stenting in all the side branches as shown here. And this was followed by final quadruple kissing balloon dilatation. And we obtained very much acceptable result as shown here. So to perfectly fit all lesions, of course, we don't want to induce left main dissection. So we used the area preservation formula like this, and we came up with a left main diameter of 4.76 millimeter if you want to use 4 stents as we use in these patients. So of course, we need 4 pairs of hands to do the procedure, and this is the situation the cath lab at that time. So we obtained excellent result shown here. At 8 months angiographic follow-up, there was no restenosis, and the distal lamin showed a very small aneurysm, which is of no clinical significance at all. He lost to follow-up and came back 7 and 5 years later because of exertional angina for 2 months. And the angio showed the instant restenosis in the proximal LAD, a new stenosis in the mid-LAD, a new stenosis in the proximal and mid-LCX. So we fixed this with 2 overlapping stents in the LAD, and good result, and also 2 overlapping DAS in the LCX, and we obtained excellent result. This is just to show the result of the stenting. LAD and LCX appear dominant as compared to both intermediate branches. 10 years later, the patient showed up again because of recurrence of exertional angina. And this time, the left main had very nasty looking lesion, diffuse and critical stenosis here. And there was a focal instant stenosis in the ostium of the LAD, LCX, and all the side branches. So again, we have to use double guiding catheter technique. Shown here, we did the sequential followed by quadruple kissing balloon dilatation, and we use DES EB to treat the LCX stenosis and DES to treat left main to LAD, the narrowings here, and then we finish the case with op in the left main. And we obtain excellent result like this. The narrowings in the intermediate branches were left as they were. 11 years later, patient showed up without any complaint, just for follow-up. And there was a very focal instant stenosis question mark in the ostium of the LCX and both intermediate branches. All other stents were patent. OCT showed well-endothelialized stents in the left main and the LAD and penetrated instant stenosis in the third ostium. We did also functional study. QFR from the left main to the LAD was perfect, 0.98. And then we did also IFR, and IFR in the left main to the LCX was 1, and QFR 0.98. So good result. And this is a view of the LCX, and the ostium looks perfect. And patient was therefore put on optimal medical treatment. Summary. So this is a patient with non-STEMI caused by left main quadrifurcation stenosis, modified Medina 11111. Patient was in a high risk for PCI and cabbage, successfully treated with a quadruple stenting of the left main and all side branches. At 8 months, all stents were patent. At 7 and 5 years, there was new stenosis in the LAD and LCX and instant stenosis in the LAD, treated with stenting. At 10 years, there was left main stenosis and focal instant restenosis of all side branches, treated with quadruple kissing balloon dilatation, DEB in the left main and LCX, and stent in the left main to LAD. And at 11 years, stents in the left main LAD were patent. There was a minor penetrated instant stenosis in the LCX ostium with good flow, and instant restenosis of both intermediate branches, treated with optimal medical treatment. And this is summary of the summary. Do not fear failure, but rather fear for not trying. Thank you.